All right, well, let's jump in. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative, and we're excited to welcome you all to our next episode, if you will, of our conversations on the business of health. The Hopkins Business of Health Initiative is a university-wide initiative at Johns Hopkins. It brings together scholars across the university who are interested in studying and understanding ways to improve the affordability and equitability and equitable nature of our healthcare system and push for high value care. And our work focuses on the role of business and incentives. And we're pleased to have a discussion today with a set of experts to be introduced shortly by our moderator, Joe Levy, who is an assistant professor in the Department of Health Policy and Management in the Bloomberg School of Public Health. And we're excited to have you today for our conversation on GLP-1s and employers taking a health equity lens. Joe, I'm going to turn it over to you.
Thank you, Dan. Thanks so much for the intro, and thanks to everyone for being here. And then I just wanted to, first of all, thank our panel so much for agreeing to participate. So I'll give some formal introductions in a few minutes, but thank you to Katie, Greg Daniel, and Shantanu Nundy for participating in this panel on GLP-1s and employers. So the way I think we'll do this, I'm going to do a little bit of introductory slides on GLP-1s. And then we'll do some formal introductions to this group and then give everyone, 5 or 10 minutes to kind of present about what their organizations are working on and sort of their perspectives on the current state of GLP-1s. And then we'll ask some questions of the panel, and I really kind of encourage everyone online to contribute to the Q&A. We're going to try and get to as many, user presented questions as possible. So with that, let me do a couple of sort of introductory slides. So, I know there's lots of different backgrounds, but, GLP-1s is the topic of the day. GLP-1s are a class of medications that modulate the creation of glucagon inside of the pancreas, and they've existed for actually a couple decades. And these drugs were initially developed to treat diabetes, and they have shown quite significant effects in treating diabetes. So we're sort of known, there's been sort of a history of multiple products that have been developed, but they are known to improve A1C. They're often used as a first-line treatment in diabetes, where they have been shown to kind of prevent the need for use of insulin or prolong not needing to use insulin. And they've been sort of tremendously beneficial to patients with diabetes. Recently, though, and as more and more GLP-1s have come to market, there's been this increased finding that they really suppress appetite. And now there are actually several GLP-1s on the market that are indicated and approved to treat obesity and to treat even overweight patients with certain other types of comorbidities. So we see on the right this graphic that was kind of from kind of the big sort of first clinical trial, uniquely looking at weight loss and uniquely looking at obesity. And these kind of first results were quite large, and this sort of large effect of semaglutide given to patients reduced body weight by about 15% on average compared to placebo, and with sort of sustained results. So you can see that's going all the way out to 2 years. So, it's kind of, this was this large result that really kind of sparked, a lot of interest, let's say, in the use of GLP-1s to treat obesity and to treat even overweight patients. And I think it's important to note there are many, additional comorbid conditions that are now being studied with obesity, where we're seeing, increased numbers of clinical trials and soon to be, we think, approved indications where these drugs are going to be used to treat more than just obesity, but sort of many things that co-occur with obesity. So historically, I sort of mentioned this, but over the last 20 years, there's been sort of numerous GLP-1s. But what we're really kind of talking about today is this sort of class of medications that have recently received these weight loss, or they become indicated for chronic weight management. So you can kind of see here, there's multiple GLP-1s. An interesting thing to note here, all of these were initially approved to treat type 2 diabetes, and they sort of sister products have been developed and now have actually been approved in 2 instances to treat weight loss. So you see kind of Ozempic is kind of this brand name that we've heard a lot about. Technically is indicated to treat type 2 diabetes, but it has a sister product, Wegovy, that is used to treat weight loss. And really, it's the same molecule at a slightly different concentration. One of its even newer competitors, Mounjaro, also has a sister product, Zepbound. So we're going to hear a little bit more about these 2 medications coming up. And I mentioned this, and this is sort of a busy slide, and we don't need to go into all the details, but there are many trials underway, using these molecules and even new molecules being developed to treat weight loss and things that co-occur with obesity. So earlier this week, sort of that second line, this SURMOUNT trial released some top-line results where they were looking at patients with obesity and with sleep apnea and have shown some preliminary positive results in actually sort of reducing the condition of sleep apnea. So sort of positive results, not just on impacting obesity, but on sleep apnea also. And you can see many of these things we know to co-occur with obesity are potentially, in the pipeline, and they're going to be sort of potentially approved to treat sort of multiple things going forward. So of course, this is going to put pressure on payers and insurers and state Medicaid agencies to start, covering more, or really to start covering some of these weight loss medications when we've shown, potential, tremendous clinical benefit potential for these medications. So sort of given that, what's actually happening on the ground today? And I think, we might see results like on the previous slide and say something along the lines of, this is great. We have these new medications that are, going to reduce comorbid disease. They're going to reduce obesity. We're going to have, great public health impact of the availability of these medications. And unfortunately, there are some challenges. And one of the big challenges is these medications have a fairly high price tag. We'll probably discuss this as we kind of get into the panel a little bit, but these medications are somewhere along the line, especially for weight loss, of $700 to $1,000 a month. And it looks like they'll sort of need, and the way they're being marketed are often, these are going to be chronic medications. So sort of this idea of having a large, budget impact and also, particular cost of these drugs is fairly high. And what we're seeing, in sort of the marketplace, this was an article actually published yesterday in Politico, was big health systems and big employers like the state of North Carolina are sort of making decisions that they're not able to cover these drugs at these current prices. And this article actually kind of explores this dynamic kind of playing out in a very public setting where the plan sort of was trying to limit access sort of to patients in the state of North Carolina, and sort of the manufacturer responded saying, we're gonna charge kind of the full price, not this maybe discounted price that is often negotiated for medications like this. And what that has led to, at least currently today in the state of North Carolina, the health plan for the public employees is not covering Wegovy. It's not covering the weight loss indication at all. And this dynamic, which we're going to hear quite a bit about from our panel, is playing out in different employers and different health systems kind of throughout the country. This push and pull of wanting to cover these drugs to treat patients, but also this sort of high budget impact and sort of how our plans and how our employers going to sort of deal with the fact that people want access to these medications and they potentially have significant population health relevance. The last thing I'll say before I'll turn it over to our panel, we know for these things that GLP-1s treat, there are tremendous kind of disparities in type 2 diabetes and also obesity across sort of multiple different characteristics. So we know that there are racial disparities in obesity. We know there are geographic and certainly income and socioeconomic disparities in the incidence of obesity and really the incidence of type 2 diabetes. And what's important, from what we're going to try and talk about today from a health equity perspective, if there's going to be these barriers to access, are they going to exacerbate these disparities? And I think this is kind of a really important thing for employers and society to really start thinking about, is how can we make, access to these medications equitable? And, are some of the things that are currently going on in these negotiations actually going to lead to sort of a greater disparities This was a publication, we're still sort of developing data here, but this publication was sort of looking at, patients with type 2 diabetes, where are there disparities in who was getting GLP-1s? And you can kind of see, sort of in these adjusted regression models, different sort of lower rates of uptake amongst racial minorities, amongst lower income populations, and obviously some geographic variation. So I think that's sort of me trying to level set, and sort of now I really want to turn it over to our panel, our real sort of experts in this area. So the way we're going to do this is each person is going to have 5 or 10 minutes to talk about their organization. We're going to go actually first will be Shantanu Nundy, who's an MD and an MBA. He's a practicing primary care physician at Neighborhood Health, which is a safety net clinic for underserved patients in Northern Virginia. But he's also the chief health officer at Accolade Inc., which provides personalized healthcare to 12 million working Americans through their employers. He also recently wrote a book, Care After COVID, about reimagining the American healthcare system, and is actually one of the pioneers of proposal of this quadruple aim, or sort of adding health equity as one of the primary goals of healthcare. Then we'll have Katie Bay, who I like her title. She's the global head of total rewards at Sedgwick, and Sedgwick is a firm that works with employers to design benefits packages for employees. And that's not just sort of the health insurance, but the compensation and sort of other ancillary benefits that member employees of her employer organizations work with. Sort of her job is to sort of create to enhance the lives of the employees of her firms, while also keeping an eye on the cost for the companies that contract with them. And finally, we'll have Greg Daniel, I'm sorry, who's the vice president and head of global public policy at Eli Lilly, which is one of the drug manufacturers of one of the GLP-1s that we'll be talking about quite a bit. He's responsible for identifying, assessing, developing public policies in the area of biopharmaceutical access, affordability, innovation, and health equity. He's a health economist by training, and he's previously at the Duke Margolis Center and at Brookings. So with those introductions, thank you all for being here, and I'm going to turn it over to Shantanu.
Awesome. Thanks so much, Joe. I think from my perspective, I think the question that I think about a lot is, how do we ensure that the people that need and would benefit from these medications the most get them, right? Whereas I think a lot of innovation in healthcare reaches those who need it most last, or not at all. And so, I'll keep my remarks really brief, Joe, but I think the two hats I wanted to put on was the sort of my hat from practicing medicine, and then also my hat at Accolade. And so from the medical side, I thought I'd actually just contextualize this conversation with a patient of mine who I couldn't get on a GLP-1, who I think needs it. So, Mr. GR, as I'll call him, is an amazing guy. He's in his late 40s. His BMI is 43. He does not have diabetes. He also has a number of chronic issues. So he's got chronic back pain. He's got a disc herniation, which is probably related to the obesity. He has asthma, which I think is also exacerbated by his obesity. I think he's got sleep apnea, but it's been really hard to get him in for testing. It's hard to spend a night in a hospital to get a sleep apnea test. And he also has serious mental illness, and he's on multiple medications for that. He lives in a one-bedroom apartment with his mom, his sister, and his niece. He works part-time at night, sleeps during the day. He shared with me that he sometimes can't afford food and just kind of does junk food. He thinks his neighborhood's safe, but it's hard for him to exercise just because of his different medical issues. In our clinic, tries to do the best for folks like this. We do have nutritionists on staff, but that means more appointments to clinic, and it's hard for him to get there. And so I just wanted to paint this picture when we talk about health equity and sort of talk about, a patient like that. And you can think about, obviously the social determinants and barriers that he's facing. You could think about the health impact that he would have if we could help him lose weight. Maybe it would improve his back pain. Maybe it would improve his sleep. It would certainly improve his risk of chronic conditions. And sort of just the challenges that someone like that faces. You can sort of get a mental image of that. So I wanted to just paint that picture as we talk about health equity and kind of put a human face to it. If I switch hats now to my sort of Accolade hat for a moment, so we get a chance to help improve the health of about 12 million working Americans all around the country. And I had my team just run some data just to help me understand the problem and frame the conversation. So the first is when we ran our data on a subset of our population, around 2 million Americans, we found that at least 3% of Americans of our population had at least one script for a GLP-1 in the past calendar year. So 3%. 25% of those people did not have a coded diagnosis for diabetes or for obesity. So a full quarter. We found that this was interesting. Those that lived in a healthcare desert, a HIPSA, they actually had a 33% higher chance of getting the prescription for GLP-1. But we weren't able to control for rates of disease and stuff. So it could be that it's a sicker population in the healthcare deserts and not. We found that folks with a language barrier had a 25% lower rate of GLP-1 prescription than those without a language barrier. And across the board, we found the adherence rate. We created our own simple measure of adherence, but the adherence rate for GLP-1s was 53%. Right, so meaning that most people aren't taking the medication as prescribed, and we don't have a way to know if they're also getting the clinical trial you showed, right, Joe, had people that were on the medication and got lifestyle changes. We don't have a simple way to know if these folks also were undergoing lifestyle changes. So just thought I would contextualize the conversation with some data and just a simple patient story, but I think it shows some of the real world challenges that both employers, like my colleague Katie, are going to talk about, but also challenges that patients on the ground and the providers like myself trying to take care of them are trying to face as well.
Great. So let's turn it over to Katie and hear a little bit more from the employer side.
Yeah, so at the employers, it's been an interesting journey of sort of, you can see the onset of the drug costs coming through and then having to work to build a strategy. And so as I look at it from an employer's perspective, we want to ensure high quality of life for our participants. It's always our number one goal. But then we also have the fiscal responsibility of how do we control those costs? And so how do we maximize the results both for the employee and the employer? And so that's sort of that position that we're in. From a benefits professional perspective and the employer lens of, we know there's a big pipeline for GLP-1s to come. And so we need to start building that strategy now, making sure we have the right controls, the right measures into place. And so as the market continues to trend towards higher utilization of these drugs, then we need to have a plan in place. And so as we're building the plan, I think it's also important to have a pulse on your population and who's covered on the population. And I think one of the factors being is, what are the demographics, where do they reside, but also what is the average tenure of your organization? And so we know that there's an investment into the GLP-1 drugs. And so if you have a short-term organization that has high turn, then you may take one approach. If you have a population that has a mid to a longer term tenure, then you're going to take a different approach. I think that right now the ROI and the GLP-1s aren't necessarily known. And so do we invest in the prevention of what chronic conditions will come? And that's sort of the position to take. From a Sedgwick perspective, we've got about 3% of our population that's morbidly obese. And of that population, 12% have chronic claim spend that is $50,000 or greater. And so if we're looking at that claim spend, do you want to invest in the prevention of what those future claims will grow to? Or do we want to go ahead and restrict them? And so I think from my perspective, based on that number alone, it shows that our population needs help and that it makes sense to have this category covered, both for the diabetics, of course, as well as for weight loss. And so I think I'm an advocate of covering them on the plan. And I think I look at it as well of, we've always covered weight loss surgery. And so this is an alternative, an alternative to that. And so making sure that there's synergies within the plan and what you considered as covered. And so I'm here to help support and build out that strategy and listen to the conversation and go from there.
Great. And now let's turn it over to Greg.
Sure. Thanks. First of all, thanks for inviting me. This is a great conversation, and happy to follow Katie, which she points to a lot of important considerations that are being grappled. I'll touch a little bit on obesity, a few points there, some on health equity, and then I want to turn to some of the analyses and data that we've analyses that we've conducted in partnership with global data on how obesity affects specifically employees and employers. First of all, no one questions whether people with diabetes, cardiovascular disease, hypertension, dyslipidemia, whether they should have access to comprehensive care. Yet when it comes to obesity, it's just thought of differently. Unfortunately, access to care is an open question, and one that often turns to, as Katie was discussing, like ROI. But no other condition like diabetes or hypertension do people think about, like, first, what's the ROI? And then if the numbers are right, we'll cover. And that's unfortunate. And I think it comes from sort of, despite a decade of clinical societies considering obesity as a chronic disease, often people in the healthcare system and in the general public just don't view obesity necessarily as a chronic disease. They view it as a lifestyle problem that doesn't necessarily deserve medical attention. But when you look at obesity, and Shantanu provided a good picture of what this actually looks like for people, is that, essentially you have physiological, sociocultural, genetic, environmental factors that all influence a person moving from overweight to obesity. And once they're in obesity, they have significantly increased risks of over 200 medical complications. In fact, one of the analyses showed that adults compared to adults with healthy weight, those with overweight or those with obesity have 12 times the increased risk of developing 4 or more chronic conditions. Yet our healthcare system thinks about, of course, we'd cover those, consequences of obesity, those chronic conditions like diabetes and cardiovascular disease, but we don't really think about obesity itself, oftentimes, as a medical condition that needs coverage. So we firmly, and I appreciate Katie with that sort of those considerations, and as she talked about, it is something that employees need to have covered. When it comes to health equity, this is a disease that disproportionately affects communities of color. So African Americans compared to whites have 30% higher risk of developing obesity. Hispanics have a 20% higher risk of developing obesity, and four out of 5 Hispanics or African Americans have overweight or obesity. So it is an issue that is disproportionately affecting communities of color. When we turn to the employer and employees, first I want to talk a little bit about employees. So we've done some recent analyses, as I mentioned, with global data, and they put these results out. Women with obesity are disproportionately impacted, suffering from 20% lower employment probability and 9% lower income compared to their healthy weight counterparts. The experiences of employees within the work environment experience stigma, negative stereotypes. They're often treated as and thought of as being lazy or less competent and having, lacking self-discipline. And that's a problem. And due to this structural issues with stigma and bias against obesity, not only in the workplace, but we see that across the healthcare system too. From an employer perspective, producing some results, Joe, I know you like that. Medical costs, average healthcare spending for members of large employer groups are about 2.7 times higher for people with obesity compared to employees and their families who don't have obesity. It's associated with 7 to 14% higher costs due to absenteeism, 30 to 140% increase costs due to short-term disability, and then also long-term disability, about 7 to 95% increase in costs associated with long-term disability, and 30 to 40% higher costs due to worker compensation. Similarly, people with obesity are absent from work about 3 or more days per year due to injury or illness related to their obesity compared to healthy weight counterparts. So it is a significant, if you look across the board, even if we're not covering treatment for obesity, there is a significant amount of expenditures going toward obesity. So we're already paying significantly for obesity, and we need to move toward thinking about how do we reduce obesity in the population. And then, so from an access parity, that's an issue. We do think that people with obesity deserve access to comprehensive care, not just anti-obesity medications that you talked about with the GLP-1s, but also behavioral lifestyle changes, surgical modalities as well. Those are important. And I'll just leave with another analysis that 5 to 25% of weight loss among employees and their adult dependents give rise to about $153 to $326 billion in medical cost savings over 5 years. That's significant, and it's an important thing to consider. So I'll just pause there and look forward to the Q&As.
Thanks so much, Greg. It was great to sort of hear some of those numbers. So maybe I'll kind of kick it off then with a question. So Katie, you kind of intimated that this kind of short-term versus long-term, different types of employers with more or less churn, are potentially making different decisions. And then in sort of light of some of these numbers that Greg is talking about, I'd be curious, how are those decisions actually getting made by these firms? Are they considering things that Greg has, indicated, things like decreased absenteeism from reducing obesity, or is it more of this, return on investment, pure sort of medical spending dollars? How are employers thinking about that? In sort of making these investment decisions?
Yeah, I think we've been more in this reactionary type of situation, because all of a sudden we start seeing these drug trends that are popping up, and I think many employers they weren't ready and prepared for this drug class to start hitting their top 10 drugs, and so they're reacting to how do we control, what measures we put into place to control the cost around this. Where I think some of these points employers need to zoom out, and how do we provide plan participants and employees a quality of life, and is it through access through equitable drug and medical coverage, or is it through a combination of lifestyle management support? I think that's where there is going to be this pivotal change, where employers, they recognize the need and the requirement to cover these drugs, and then how do we look at it from a holistic perspective? Because I think overall there's leakage across organizations due to these chronic conditions. And so how do we look at those more holistically versus just narrowing in on the drug spend? And so I think we will start to see the shift from an employer's perspective for more of that holistic view here.
Great. Sort of a couple people now have mentioned these lifestyle management support, ancillary maybe to potentially getting, some actual GLP-1 treatment. Could we maybe hear a little bit more, from someone, sort of what does that actually mean? Sort of what are these lifestyle management support plans, and sort of, how are employers thinking about, enrolling in one of those, and how that potentially is going to impact their spend, maybe either up or down on the GLP-1 products?
Yeah, I'll kick it off, because I think you guys probably both have a variety of comments on the question as well. I think from an employer perspective, our number one goal is get the participant healthy, get them in a high quality of life, but then also get them in a state where they don't have to be reliant on a drug. And so if, a drug is the primary sort of track to get them on the right path, but then also adding an alternative and in conjunction with a lifestyle program. There's a lot of new solutions to the marketplace, and I think that they really vary based on the participant of what works and sticks with their lifestyle. And I think giving them access to that type of education and sort of white glove approach of, this is a way that you eat healthy, or this is a way that you take daily walks, will also add as a nice complementary add-on when actually utilizing the GLP-1s as well. So that's just an employer's perspective.
Yeah, and I'll just add on that these drugs aren't intended to be used by themselves. They are indicated for, and societal guidelines are showing that these are intended to be adjunct to these lifestyle modifications as part of a comprehensive approach. So they really do need to come together.
Yeah, I mean, the only additive thing I'd say is I think, yeah, it's absolutely critical. And I think the question from a health equity perspective is, how do we ensure that we aren't increasing barriers to the medication and instead sort of decreasing barriers with this. So one of the things that we're seeing some employers do is they're actually saying, well, you need to do 3 months of these lifestyle changes before we can start the medication. And while I understand the sentiment there, I think my concern, and there's no data that I'm aware of, but what I'm concerned about is oftentimes what these lifestyle interventions require is that you're going into a nutritionist office or something like that 1 or 2 times a week. Well, who are the folks that are most likely to not be able to make those appointments for 3 months and face barriers to transportation and access and time off, et cetera? Well, it's the folks that come from those marginalized communities who have, as Greg said, a higher proportion, disproportionately are impacted by obesity and the comorbid complication of it. And so I think the approach that we're taking at Accolade in terms of how we're designing these solutions are, what are the types of lifestyle interventions, kind of like Katie said, that actually make it easier for them to be able to access it so that they can do it in parallel, right? So a good example of that would be there's a number of organizations now that have taken really sort of evidence-based approaches to lifestyle, whether it's diet, whether it's exercise, and sort of created, mobile applications that allow them to get bite-sized chunks of it, allow them to get asynchronous coaching from a coach. Those are things that, provided you're not on the other side of the digital divide, people can access fairly easily. And that actually what we find is folks that come from marginalized communities actually prefer that kind of communication modality for themselves anyways. And so I think thinking through those sort of design considerations and thinking about equity from the start, I think we can achieve those aims while at the same time ensuring access.
Yeah, that's absolutely fascinating, and I think sort of thinking more about these access barriers, and increasingly in our healthcare system, the use of formulary design and the use of prior authorization and the use of step therapy are seen as techniques that are potentially going to control spending. So maybe kind of hearing from the panel, sort of what are some unique things about prior authorization, or sort of these attempts to control spending in this particular space, and how could we maybe target better, as opposed to sort of putting this administrative burden on physicians where they need to sort of prove that this person needs this medication.
Greg, were you going to jump in there?
No, I wasn't, but I can.
I was saying, but when I hear the word prior auth, it certainly rings a bell for me. I just got a patient of mine on a GLP-1 after a 6-month ordeal where, I had to start with a non-GLP-1 medication. Then I had to get them onto another earlier GLP-1 medication. In that case, it was Byetta. And then I finally was able to get them on a GLP-1. And I will tell you that it's one of those things where, again, day one, 6 months ago, I knew what this patient needed. And yet to go through every single time I had to prescribe the medication, they got rejected at the pharmacy, then they had to finally get it, then they had to come back, then I had to write in the chart, well, they took the medication, but it didn't work, or they took the medication, they didn't have a side effect. I mean, it's an incredible ordeal in order to do this. And I would say that this patient was successful, but for every patient like him, I have 9 more who I can't get through the gauntlet, largely because they just can't come in that frequently. They can't pay a copay that many times for all the first line, second line, third line. And I think I understand the intent, but it's definitely creating, I think, a number of these equitable access issues. So.
Yeah, and I'll jump in. I mean, I think that's where the challenge that we see as well is that, we want to make sure that the right patients have access to these medications. So for a BMI of 27 or more, plus a comorbidity, or a BMI of 30 or more, with or without a comorbidity, those are the patients that deserve to have access. And I understand the use of these tools like prior authorization, and oftentimes they can be a blunt tool that's just not sensitive to patients who making sure that the patients who need the medication but may not have, as you point out, Shantanu, immediate access to be able to go and go through all of the hoops. Can we get smarter, more efficient with these tools that payers use to make sure that the patients who aren't supposed to be getting these just can't, whereas the patients who are in these categories that actually need access to these, that's as efficient possible for them. So I don't know what that looks like, but you know, there are digital technologies and other more advanced ways of thinking about these. And how do we make sure that those patients who are indicated have efficient access as much as possible? Because we see, you know, as you point out, like people falling off, and though they might have a need, and the physician and patient discussions have determined that it's appropriate for them, but yet what happens when, you know, down the road when they actually can't get access, or they go through one or two um, um, denials, if you will, and then how much will they be willing to push that forward, especially when we know that patients with obesity suffer from this, like, you know, poor experience traditionally with the healthcare system anyway, where they just have not been treated seriously, or that they have a chronic condition, you know, by the past care that they've had. And so they're more likely to be like, well, why should I put forth the effort to go through all of these hoops when the healthcare system just doesn't recognize, you know, that I do have a disease? And it's tough.
I think these are all very interesting perspectives, because I think from an employer, who we're the ones sort of putting in those controls and those prior authorization requests in conjunction with the pharmacy benefit managers and their recommendations. But I think it's a process that is probably sort of outdated now. And what we're just trying to do is like, hey, just make sure that there's other options that have been used before going to a higher cost. And so I completely acknowledge and agree that those are likely now an opportunity where there should be some new innovation around that space, so that those that need it get to it faster before they fall off the spectrum. I think one stance that we're doing is, we're doing two things around the GLP-1s, is we are putting a BMI sort of threshold for that eligibility. And so we just want to make sure that we have the right eligible population in it. The other stance that we're taking is, let's limit the drug fill at the onset to ensure that we're reducing product waste. And if the participant doesn't continue with the drug because of side effects or so forth, can we limit, you know, stockpiling or wasted product? And so that's, you know, one control measure that we're putting into place to try to mitigate that without having to go through the hoopla of a prior authorization.
Yeah, I think that makes so much sense. I mean, I think the other thing that I don't think is said a lot in the physician community, but you know, there's a common, you know, statistic that, right, it takes 17 years for a new evidence-based intervention to reach the mainstream clinical practice. And obviously GLP-1s are happening a lot faster than that, but what's happening on the ground, candidly, is I think a lot of physician practices aren't yet set up to be able to appropriately prescribe, monitor, and ultimately graduate patients from these medications, right? If you think of the average doctor out there, average PCP, they're probably, you know, filling this medication a few times a week, or maybe a few times a month, and they don't have systems in place yet in order to, you know, make sure that you've completed a full assessment, have a protocol so that they're getting their labs checked before the medication's prescribed, that they're seeing them frequently enough to titrate up the medication and ultimately see if the weight loss goals are met so they can graduate them. And so one of the things that we've been advocating for, putting my Accolade hat on, is, you know, having like almost having like a centers of excellence approach, where you're providing patients access to a smaller subset of physicians who have like a high volume of these types of patients, and who have protocolized the entire process. And so we've done a fair bit at Accolade. One of the components of our service is we have primary care physicians. They all receive specific training in GLP-1. They all have a specific patient self-assessment that gets completed prior to the first visit. We have a policy that says you can't prescribe the medication at the first visit. It has to be at least at the second visit after laboratory tests are done. And we're just at the early innings, honestly, of being able to develop an end-to-end pathway, including things like graduation from the medication. But that's, I think, the direction, I believe, where you can balance this issue of, you do want to control costs. You want to make sure people are appropriate on it and staying on it until they reach their endpoint, while at the same time avoiding kind of the blunt instrument of prior authorization. You know, put it in the hands of physicians that have the experience and sort of protocols and policies to be able to do this in a way that's actually effective. That's our point of view.
Yeah, that's so fascinating to sort of hear about this idea of, you know, a center of excellence for, you know, a place to go get this care. And it just seems, maybe a comment is, how all of these different employers and all of these different insurers are going to be setting different criteria and setting different guidelines. We're sort of hearing that from Katie, where, some are going to set BMI, things and other types of, barriers to control spend and access. And it just seems like such a hard problem to solve, to sort of come up with one approach that is going to, sort of lead to the efficient delivery of this care. Katie, could you maybe tell us, a little more about, all of these, how, hearing about this prior authorization process from these three different perspectives is so fascinating. But you get even more because you sort of deal with these employers who are making these, bespoke kind of individual decisions. So like, how does an employer, come up with the idea like, oh, we're going to set this BMI cap, or we're going to require you to enroll in XYZ, technology lifestyle modification program? And maybe I'll just sort of add, there's lots of kind of data growing on, state health plans kind of doing things like this and requiring enrollment in, XYZ program as the first step in getting access to a weight loss GLP-1.
Yeah, and I don't think there's one right answer, but I think that there's a lot of different voices at the table, I would call it. Employers sit closely with their consultants that have a pulse on what other employers are doing in similar like spaces. We've got strong relationships with our pharmacy benefit manager that help us understand claim utilization. We also see claim trends, and through our medical TPAs, we're seeing where our top spend is. And so we start to grow our thoughts and inform ourselves around what is right for our population. And then it's a cultural thing as well. The last thing we want to do is implement benefit offerings and controls that doesn't meet with how we are from an employee experience and a cultural perspective. And so I think with all those different elements and an evolution of keeping a close pulse on that, we're able to come across a decision that is probably, a decision for a given year, and then it has to continue to change. And I think from an employer's perspective, staying fresh on what's going on in the marketplace and making sure that when you're spending that time making those informed decisions for the next year's strategy, that you're looking at it from many different facets and you're getting, a pulse on what other employers are doing, what's going on in the marketplace, but continuing to evolve. And I think that's where keeping that fresh understanding of the marketplace is important.
Great. So one thing that I thought about, as several of you were presenting was this, is there something kind of unique to this class of drugs, given that, they have this diabetes and weight loss, dual use? And, sort of this, maybe Shantanu sort of indicated in some of your data where, you're seeing people weren't necessarily diagnosed with obesity or weren't necessarily diagnosed with diabetes. And there's maybe this real concern about like off-label use of, the diabetes indication, the diabetes indicated drug, being used to treat obesity, and sort of how do, these different organizations, either from Lily's perspective or from employers or from clinicians, sort of think about off-label use, and like, do these prior authorizations, is that part of what they're trying to do too, is kind of prevent you from being able to use the drug for, not its completely stated purpose? So I don't know. Somebody tell
Greg,
me about.
you want to jump in? Otherwise, I'm happy to.
Sorry, do you mind just repeating the question?
Sort of, are there unique things to this class of drugs that, have sort of led to maybe, a need to try and control, via prior authorization, prevention of, people using the drugs off label and, not, meeting the clinical indications?
Yeah, it's a problem in terms of off-label use. I mean, we see sort of the media attention and highlighting celebrities and things like that, and that's a significant problem. And it detracts from the real appropriate use of these products and the need. These are not for just weight loss. These are for treating obesity if you have obesity. And so, however we can make sure that the right patients are getting access to these drugs, we need to focus on that. But the disservice that the media and this sort of like lifestyle, like weight loss with these products has really done a disservice to real people who have obesity that now may not have easy access because of all of these problems that have caused these sort of knee-jerk reactions of like overemphasizing restriction. So that is a big problem.
Yeah, I mean, I think totally, Greg. I mean, I think from my perspective, right, there's only two medications patients ever walk in asking me for, right? It's antibiotics for sinusitis and it's GLP-1s, right? I mean, that makes it, Joe, I think, very distinct.
Yeah.
And I think that so that's why I think some of these prior auths effort definitely have the right sort of concept behind them, right? So for example, you know, at Accolade, you know, we do a lot of virtual primary care visits. One of the things that we notice is that people are having to type in their BMI, right? I mean, we don't have the ability to weigh people. It's a virtual clinic. But that lends itself, right, to folks you know, putting in their BMI as 26.5 or 24.5 or whatever it is. And so it's absolutely a fair concern. And to me, it goes back to the way we design these systems, right? Like, does it make sense to be able to provide someone, for example, a wireless, you know, weighing scale and use that as a data point? I mean, compared to the cost of the medication, it's minuscule. And checking your weight on a regular basis is actually a very effective behavioral technique to drive other sorts of lifestyle changes that we want. It could also measure, for example, the therapeutic endpoint to say, hey, actually, you've now lost your 20 pounds, which is your goal weight. Maybe let's start to talk about whether or not we could potentially graduate you off of these medications. And so I think we have to acknowledge that sort of patient-led, consumer-led demand is a real phenomena. We have to be careful, like Greg's saying, not to have white blanket policies that then make it harder for those who need it to get it. But I think that's where, you know, thoughtful design, I think, can find the middle ground.
Great. So I think I'll ask one more question, then I'm going to kind of turn it over to the Q&A. Maybe this was intimated already in the Q&A. Thanks, Shantanu, for responding to some of these. You know, we sort of know, when there's been a lot of national media attention, there's somewhat of a supply constraint currently for, you know, the big GLP-1s, you know, Ozempic and Mounjaro, and then obviously their weight loss indications. I guess sort of, you know, asking the group, you know, is this supply constraint going to go away? And also, is it currently kind of impacting practice? You know, how do you deal with this supply constraint as far as, you know, making prescribing decisions? And do you see, you know, if this is going to go away, you know, is there going to be more pressure, you know, on plans to be covering these drugs? And maybe just speak a little bit about kind of what's going on with shortages for these drugs, and we hear that people are not able to access them.
Yeah, I'll jump in on the supply. That is a serious concern that we're looking at, and I know Lilly, as well as Novo, have made recent announcements in significant investments in manufacturing capacity. We made an announcement. Speaking of North Carolina, that you started, we're actually, you know, added manufacturing sites in North Carolina to support the supply here, as well as made investments in other many other of our manufacturing sites in order to increase production and supply. So it is an issue, and we are hoping to see that attenuate over time as we ramp up and increase. And Novo has been making similar sort of expansions in manufacturing as well.
Yeah, I mean, so from my perspective, I mean, it's had a huge impact, right? I mean, I think just to prepare for this, I asked some of my colleagues who see patients 5 days a week or 6 days a week in my clinic. I said, you know, do you prescribe GLP-1s and when? And a bunch of like, we don't even bother. We don't even bother because it's been so difficult for patients to get it. And then if they do manage to get it, for there to be enough of it next month and next month, because again, you're not going to get sustained weight loss or even significant weight loss unless you get it multiple times. So I think there's that trust piece. So I think as supply comes online, like Greg's saying, then I think there's going to be a little bit of a lag time before physicians start to feel comfortable that, hey, the medication is going to be there and continue to be there for patients. On the Accolade side, we actually partnered with a compound pharmacy in order to address this access issue. There's I don't know the exact regulation, but there's a regulation that says that if there is a shortage of a critical medication, that compound pharmacies can then come in to boost supply. And so that's what we've done, again, with the idea of ensuring access to sustainable weight loss. And so that's been really effective for us to be able to manage through this hopefully temporary supply issue.
I'd
Yes.
also add, I saw there's a question in the chat about this, and I'll answer one part of it, which is that, we've heard that in some cases for these GLP-1s, that the pharmacies aren't necessarily being reimbursed by PBMs at their acquisition cost. So in many cases that we've heard is that the pharmacies are being reimbursed lower than their acquisition